data regarding prevalence of valvular heart disease, what is the current management of valvular heart disease in real world, and how we can improve this management of patients. I will go fast on the first slide. You have seen again that the prevalence of valvular heart disease is very high. If you look at patients above 75 years, 11% of them have significant valvular heart disease. We know that our Western population is aging, and if you look at the population in Canada, we have currently 7 million of patients that are more than 65 years old, and we expect that to have more than 12 million in 2063. I looked at that yesterday in Israel. You still have a young population here. Rate of people above 65 years old were around 10 to 15% in Israel. Oxvalve studies has been alluded to by Dr. Messana. Again, if you screen in the population more than 65 years old, you find that the expected prevalence of valvular heart disease is currently 1.5 million in 2015 in UK and is expected to double in 2050. Swedish population, they are very good. They have registry of almost everything. Here they were able to capture the entire population of Sweden. And you can see again a huge increase of the prevalence of valvular heart disease here, AS with aging. You can see how high is the prevalence and a little bit lower of mitral regurgitation. What is important to know is that we know we have AS, we have MR, but we have emerging valvular heart disease that are coming. We look at that in the paper we recently published. We look at patients with calcific mitral valve disease, which is MAC, involved with the leaflet, with significant MR or significant MS. In 1 year, we were able to identify 160 patients with severe calcific mitral valve disease. And most of the patients, we're going to see that again later, are conservatively managed despite significant symptoms. TR is one of the work of my friend Jan Topilski. You can see that here prevalence of TR is also significantly rising with age, and currently prevalence of TR is as high as aortic stenosis. Important finding is that TR is more prevalent in women than in men. Another new entity, functional MR due to atrial fibrillation and mitral annulus enlargement. We know that in addition to valvular heart disease, AFib is a new epidemic, and we are going to see more and more of these patients with functional MR just due to annular dilatation due to AFib. In this paper on the right from the Mayo Clinic, you can see that among this kind of functional MR, atrial functional MR was accounted for half of this functional MR. So it's a new entity rapidly rising. So clearly, valvular heart disease is the next epidemic. It's a degenerative valvular disease, but it's not a passive phenomenon. It's an active phenomenon, actively regulated. We have improved our knowledge about aortic stenosis. We know that you have oxidation, lipid deposition, cell differentiation, and calcium deposition. For mitral valve disease, we know that some genes are involved, but despite our improvement of the knowledge of valvular heart disease, there is no medical therapy. The only treatment for valvular heart disease is still intervention. Most of the time is surgery. And we know that if you do nothing to patients, they die. In the partner trial, you can see how high is the mortality when you do just conservative management. If you do an intervention, they do much better. So clearly, valvular heart disease is a lethal disease if it's left untreated, and there is no medical therapy, only an intervention. And again, we have new way to treat patients, less invasive solution with transcatheter therapies. If you look at the increase of number of TAVR done, you can see here that among all aortic valve replacement in France, we increased from 11,000 to 18,000. It's not due to an increase of the prevalence of the disease. It was due that the increase of number of TAVR performed. And what happened is that among elderly patients, they were denied any intervention, but with occurrence of TAVR, this patient now can be treated. You can see in red the new population above 80 that have access to treatment that was denied before. So transcatheter therapies had completely changed the way we are managing patients with valvular heart disease. When you think about management of patients with valvular heart disease, there is three conditions. First, you need to identify that the patient has valvular heart disease. Second, you need to follow carefully this patient and send them for an intervention at a timely moment. What happened in real life? What are we doing currently with patients with valvular heart disease? If you ask patients regarding awareness of the disease, they know and they care about cancer, they know about Alzheimer's, they know about stroke, heart attack, but they do nothing about valvular heart disease. And when they go and see their physician, they have no auscultation. Half of the patients are not auscultated when they go to see their GP. On the other side, you can ask what the physicians are doing. In this survey, it was done by my friend Bernard Young, they ask physicians, what are you doing? What are your skills regarding valvular heart disease? They ask GP, cardiologist, surgeon, a wide range of physicians. And again, you see that they are not using stethoscope. Stethoscope is the first line, the most cost effectiveness way to identify patients with valvular heart disease, and it's not used in most of the cases. And again, if you do a screening by echo, systematic echo, you identify 51% above that have valvular heart disease above 65 years old. It's huge. So clearly, valvular heart disease are not diagnosed correctly. We are doing an underdiagnosis. Now you have diagnosed patient with valvular heart disease. How we are managing patients. This has been evaluated in this study from the Mayo Clinic. They have identified approximately 1,000 of patients with significant MR. You know that the patient had an MR significant. You know that it has been quantified, and it's written in the report. You send the report to the physician. What happened? First, you can see again the increased prevalence of mitral regurgitation with age. You can see that the prognosis of this patient is significantly bad. But the most important result of this study is that only 20% of the patients that have significant MR, you know that they have significant MR, you know the quantification, it's your physician has the report and nobody is acting on that. And it has done at the Mayo Clinic, it was no issue of coverage. Mayo Clinic, is one of the leading centers in the world. They have access to surgery, they have access to clip, to everything. And despite that, only 20% of patients with mitral regurgitation get treated. We look at that also in France. We look at more than 1,000 patients admitted in French hospital from 2015 and 16 with a diagnosis of mitral regurgitation. You can see that the population is 77 years in average, 10 to 15 years higher than any surgical series. So in the real world, patients are completely different than what you have in surgery. Look at the age. 50% are more than 80, 12% are more than 90. And again, a significant rate of comorbidities. What happened to them? Only 8% within 1 year get an intervention. Most of them, 92%, get conservatively managed. What is the outcome? Bad. Overall mortality at 1 year, 14%. 2/3 get either dead or readmitted for any reason, on 1/3 for heart failure. You expect that for functional MR, but even organic MR have the same worse outcome. Same mortality, same rate of readmission for heart failure. And the cost is huge. You can see the expected cost for mitral regurgitation is between 350 millions to 550 millions because readmission rates is very high. And if you look at the STS registry, STS database, you can see that again, patients are referred very late. 50% had a recent history of heart failure, 50% had a low ejection fraction, and 24% have high systolic pulmonary pressure. Patients are referred very late in the course of the disease in the US. We look at that in this contemporary registry. We collect more than 2,000 patients with AS across Europe, 23 centers. You can see again, most patients are elderly, more than 80 years old. They are frail with significant comorbidities. They are still referred very late in the course of the disease with low ejection fraction, heart failure. And despite availability of TAVR in all the 23 centers, 20% were still denied any intervention. So clearly, valvular heart disease are undertreated and patients are still referred very late in the course of the disease. Again, this survey, why these patients are so poorly managed. They ask the physician regarding their skills and knowledge regarding guidelines. You can see that most of the physician didn't know what is the difference between functional and primary MR, how to use quantification, when to do intervention. So when you have the diagnosis, you send the patient to an intervention, what happened? We look at the result of 80,000 all mitral surgery performed in France from 2014 to 16. 18,000 of patients had mitral surgery. 40% had degenerative MR, 16% had functional MR, remaining were endocarditis, congenital, and rheumatic disease. What is the rate of mortality? 6% of in-hospital mortality, mitral valve surgery in France currently. Look at rate of readmission or mortality at 1 year. For degenerative is 13%. Functional MR, 27%. Again, we know that if you do replacement, you do worse than repair. If you do combine, you do not as good as we have isolated surgery. What is the rate of repair? The country of Alain Carpentier, the rate of repair for degenerative MR in France is only 70%. If you look at a subgroup according to age and Charlson index, you can see that even in the best subset of patients, less than 60, no comorbidities, rate of repair is only 84%, so quite low. And what was striking is that even in this subset, women are less likely to get repair. Rate of repair was significantly less in women than in men. And it was true whatever the age, whatever the comorbidities. And you can see that if the rate is 84% in 60 years old, significantly lower with age. You have seen this slide. Again, the rate of repair in the US is 70%. What is even worse is that it depends on where you get your intervention. Rate of repair can be 100% if you go to New York with David Adams. If you go to another center, you can get a repair of only 30%. So it is called the lottery of mitral valve surgery. And again, regarding equality, this paper has been published last month in Circulation Outcome. You can see that access to care also is very different according to countries. If you look at the population of Ontario compared to the population of New York, same age, but Ontario gets less likely TAVR than New York. Also, you have in New York compared to Ontario a difference according to outcome. Wealthy people in New York get more access to TAVR than poor people. So clearly there is inequality in the treatment currently of valvular heart disease. What we can do? Different access. First, we need to raise awareness of the disease. People have to know what is our valvular heart disease. We need to raise campaign. You have campaign for Alzheimer's, stroke, heart attack, any other kind of disease. We need to do that for valvular heart disease. So people, the population is aware of valvular heart disease. Physicians need to be aware. Policymakers need to be aware what is valvular heart disease and what is the impact on outcome. We need to improve screening. I've showed you that physicians are not using stethoscope. Maybe we can help them. Why not using computer-aided auscultation? We are currently evaluating that. If you had a system that can help the physician to diagnose murmur, that is easy to use, maybe we can increase awareness and diagnosis of valvular heart disease. We know that the sensitivity and specificity of auscultation, even if it's the most cost-effective way to diagnose valvular disease, is not perfect. So maybe we should increase the rate of doing echo in the population. In the Hawks valve study, you can see that 50% of the patients were underdiagnosed with valvular heart disease. We have now new technology. Why not using point-of-care echo to diagnose valvular heart disease in the population? It has been evaluated in different settings. Family doctors, nurses, they are able to use point-of-care echo and diagnose at bedside patients with valvular heart disease. You need to improve access to care. Echo, it's difficult in some countries. We need to develop the kind of clinic murmur. When a physician diagnoses a murmur, they should have a specific pathways to send the patient had rapid access to echo, so the diagnosis is made very rapidly and efficiently. We need to manage this patient properly. It has been, now we have more and more evidence that this patient need to be managed by the valvular heart disease specialist in valvular heart clinic. You can see in this patient in the paper that the patient who is followed by the valvular heart disease clinic have a better outcome than when diagnosed in the community. We need to develop new innovative intervention. In the Impulse, in the registry I showed you before, we were trying to do an intervention. When the patient were diagnosed with severe AS, we were calling at 1 week the physician to tell them that their patient had severe AS, and we reminded them what are the indications for intervention. And we looked at what was the impact on the time to intervention and rate of intervention. It has been published last year. We had a small impact on the time to intervention, but no impact on the rate. But we need to develop this kind of intervention to improve the rate of referral. And when you have known the diagnosis and you think that the patient needs an intervention, you need to send this patient to a center of excellence. They need to be high centers. Should be capable of doing all type of intervention, transcatheter and surgery. And using this intervention, they need to provide excellent outcome. So in summary, valvular heart disease is clearly the next epidemic we will face. We are dealing with elderly patients with frequent comorbidities. Timing is critical, and we know that currently the management is clearly suboptimal. Patients are underdiagnosed, undertreated, they are still presenting very late in the presentation in the course of the disease, and there is inequality in the treatment of patients with valvular heart disease, even in the same country. So there is an urgent need to improve the overall management of this patient through innovative screening methods, the development of valvular heart disease pathways, including a valve clinic, and to develop valvular heart disease center of excellence. I thank you for your attention. I think I'm on time.